Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Standard Medical Notes. So the previous two ECG videos were based upon the theoretical criteria of STEMI and STEMI, unstable angina, what are pathological Q waves, okay, and in detailed explanation of different kinds of T waves schematically and also in ECGs. From now onwards, we will discuss about different type of myocardial infarctions. So let's begin with the name of Almighty. This is an important figure which one needs to copy paste in his mind whenever uh, he is suspecting an NMI in the patient, and he needs to locate the MI, which is the MI, and what which coronary arteries involved in that MI. So this figure will help in knowing all those things. So it is hiding somewhere here, hiding. Okay, I'll take this site. Okay, now it becomes okay. So see here, whenever you see an ECG, you will have this type of ECG, 3 leads ECG. Okay, 3 lead ECG. So you will have 1, 2, 3 AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. So this type of ECG you will have in 3-channel ECG. Okay, there will be 6-channel and 12-channel ECG also, with bigger ECG papers. But commonly used ECGs in primary clinics and in higher centers in emergency rooms also, it is 3-channel ECG. You will get 1-channel ECG also, where you will get only one strip, and that will be very long ECG. So 3-channel ECG is the most common ECG. Just remember this. So the leads will be like this. The leads will be arranged in this manner in those 3-channel ECGs. Now you just remember in this you just remember what are the inferior leads, what are the anteroseptal leads, and what are the lateral leads. See here, if you draw a box like this, so these are nothing but the inferior leads, that is 2, 3, and AVF. Okay, these are inferior leads. Opposite to inferior leads are anterolateral leads. Okay, so first we'll see lateral leads. Okay, we will divide into 3. One is inferior leads, one is lateral leads, and one is anteroseptal leads. So we will see lateral leads. So lateral leads are here one, and one here, and 2 here. So what that means, the lateral leads are 1 AVL, V5, V6. Okay, 1 AVL, V5, V6. But if you remember that the basic thing in the horizontal plane and in the frontal plane, the arrangement of the leads, this is not required actually. You will remember in seconds. But to have fast remembrance whenever you are seeing ECG, just remember these patterns. Now, what are the anteroceptor leads? This greenish part, this part, okay, this part from V1, V2, V3, and V4. So these are anteroseptal leads. These are anteroseptal leads. So V1 and V2 are anterior leads, V3 and V4 are septal leads. Okay, and whenever you see changes like from 1 AVL, V5, V6 plus V2, 1 V1, V2, V3, V4, see, that is called as anterolateral MI, myocardial infarction. Okay, so this you copy paste in your mind whenever you're seeing an ECG. Whenever you're seeing an ECG, no, you just copy paste this diagram in your mind. So this reddish part is inferior, bluish part is lateral, greenish part is nothing but the anteroceptal leads. Okay, now you just see here. Now I will, okay, take it up. You see this downside of this box. So inferior leads will start with. Inferior leads are 2, 3 AVF, and remember that means there is a problem with right coronary artery. Okay, or left circumflex artery, because these coronary arteries supply the inferior part of the heart. So whenever there is infarction in inferior, you see ST segment changes in these reads, that means there is something problem in right coronary artery and left circumflex artery. Which are the coronary arteries involved in inferior leads? In inferior infarction, right coronary artery, and left circumflex artery, right coronary artery and left circumflex artery. Now we'll come to the lateral leads. So bilateral leads are 1 AVL, V5, V6. So which are the leads, arteries which are involved? It is left circumflex artery or diagonal branch of left anterior descending artery. So which are the arteries which can be involved in lateral leads? It is left circumflex artery or diagonal branch of left anterior descending artery. Left circumflex artery or diagonal branch of left anterior descending artery. Okay, that's in lateral leads. So in anterior septal leads, so which will be the artery? This is very important. Left anterior descending artery. Only one. Left anterior descending. So just to revise, in inferior infarction, right coronary artery or left circumflex artery. Okay, in lateral infarction, left circumflex artery or diagonal branch of left anterior descending artery. In anteroseptal infarction, left anterior descending artery is involved. Okay, so clear. So this is the thing, these are the things which you should remember. This is a very important. You can take a screenshot of this and you can just copy paste this into your mind while saying again and again. Now we will see the ECG of each infarction. See, this is an ECG of anterior wall infarction. This is an ECG of anterior wall infarction. So you are able to make here ST segment elevation with T wave inversion. ST segment elevation with symmetrical T wave inversion V1, V2, V3, V4, V5 up to here. ST segment elevation with T wave inversion, and also you can see here there is a formation of Q waves also. So that means what will be the duration of this MI? So only hyperacute is in minutes, as we have discussed in the previous video. Hyperacute is in minutes, and T wave hyperacute with T wave ST segment elevation is with minutes to hours, and then development of Q wave is hours to 12 hours. So this ECG is duration is hours to 12 hours. So what is the duration of infarction? Hours to 12 hours is the duration of this infarction. Okay, hours to 12 hours. Along with that, you are having inversion of T wave also. So it is not hours to 12 hours actually. So inversion of T waves is nothing but days to weeks. 1 day you can say. So it is an ECG of 1 day. Patient is having infarction from 1 day. Then what will happen in months? 1 day to weeks you can think it as. Okay, 1 day to weeks, days to weeks. Then what will happen? This ST segment will return, T wave will become positive, but Q wave will persist. That is in months to weeks to months. So you should also be able to analyze the duration of infarction by seeing these things. So I am doing these things. So you are seeing sorry, okay, one thing okay. So you are seeing ST segment elevation in. So reciprocal changes confirms the infarction. So reciprocal changes, remember, when there is inferior infarction, reciprocal changes will be seen in anterior and lateral leads, and when there is infarction in anterior and lateral leads, the reciprocal changes will be seen in the inferior leads. You look at the inferior leads, there is ST segment depression in 2, 3 and AVF. There is ST segment depression in 2, 3 and AVF. So that confirms our anterior wall myocardial infarction. So what is the artery which is involved? The artery is left anterior descending artery. Which is the artery? It is left anterior descending artery which is involved, and it is STEMI. And you can see here what is the criteria? At least 1 mm in limb leads and at least 2 mm in precordial leads. So grossly you can see it is more than 2 mm, equal to or more than 2 mm, equal to or more than 2 mm. No, so it is more than 2 mm in precordial leads. So and there is J point elevation, and it is convex. The elevation is convex. ST segment elevation is convex. So that confirms anterior wall MI. Okay. Now moving forwards. So this next ECG is inferior wall MI, myocardial infarction. So that rate and rhythm and conduction abnormalities, any other things we are not going to see here. We are just focusing on MIs here. Okay. Now you see here, this is an ECG of inferior wall MI. So which leads you will see? You will see 2, 3 and AF. So 2, 3 and AVF. See, there is ST segment elevation along with hyperacute T waves. Hyperacute T waves. Now see, so it is hyperacute T waves. So minutes to hours. Okay, minutes to hours. Still the Q waves are developing. Okay, so probably this is an early phase of infarction. Early phase. Okay, early phase of infarction. How many? It is from minutes to hours. So this is very golden period, no? We can save much parenchyma of the heart in this period by thrombolysis or by PCI. So this is an early phase of infarction from minutes to hours. By seeing in hyperacute T waves and ST segment elevation only, you are deciding whether there is there. Q waves are still developing. If you take Q waves also, it is hours to 12 hours. So again, more than 12 hours you can't thrombolyze. So we will know when there is when we will go to specific chapters of MI. So more than 12 hours, less than 12 hours, when we should do thrombolysis, when we should not do thrombolysis, when we should do PCI, all those things we'll see. Less than 12 hours thrombolysis you can do. Okay, so this is, you can do thrombolysis here, provided the patient meets the criteria for thrombolysis. There are some conditions for thrombolysis. So I am now removing all this. Okay. So now, how you will confirm? By troponins, that is one thing. What are the reciprocal changes? Where you will see? You will see in anterolateral leads. Yes, you are right. So see here in lead 1, lead ABL, and in lead V5, V6. Okay, you are not able to see in V5, V6. One ABL. Okay, one ABL you are able to make out. One ABL you are able to make out. See here, there is ST segment depression. So that confirms inferior wall myocardial infarction. What is the duration? Probability is hours to 12 hours, meaning less than 12 hours. Less than 12 hours, because the T waves are hyperacute still and it is convex. And in limb leads, more than 1 mm elevation of J point elevation is there. It is approximately 4 mm elevation. Okay, so that's all about the inferior wall MI. Now we will come to, when I said one thing during discussion at some point in the previous videos. So this inferior wall MI, posterior wall MI, and right ventricular MI, these come in combo meaning if inferior wall MI is there, you should rule out right ventricular MI and posterior MI. If posterior MI is there, then you should rule out right ventricular MI and inferior wall MI. If right ventricular MI is there, you should also rule out posterior wall MI and inferior wall MI, because this can be present. And one more thing which can be present is blocks. Blocks are common in these three MIs: inferior, right ventricular, and posterior. Blocks are very much common. SC node is supplied by this right coronary artery. Right coronary artery SC node is supplied. That's why blocks are very much common in these patients. And these patients, no, these MI patients present with hypotension. That is also an important thing we should remember. Now coming to posterior wall MI. So you see here, this is an ECG of posterior. You should look at leads V1 and V2 in posterior wall MI. So you are seeing ST segment depression here of more than 1 mm. In precordial leads, it should be more than 2 mm. So it is more than 2 mm. It is V2 lead. V2 lead. How do you will confirm? What you do is you keep V1, V2, V3 at their place, these test leads. You remove the V4, V5, V6 leads, and you connect these V4, V5, V6 leads at the places of V7, V8, and V9. So this V4 will act as V7, V5 will act as V8, V6 will act as V9. In this uh, uh, altered position of V4, V5, V6, you will see ST segment elevation that confirms posterior wall MI. Or what you will do is just flip the ECG. This is flipping. Just flip the ECG. Flip the ECG. When you will flip, you will see the characteristic ST segment elevation here. See tall, very deep Q waves inverted. So it is probably You can say days to weeks duration MI. Okay, it means one day, more than one day MI. Okay, it is of more than one day MI. So that's posterior wall MI. Along with posterior wall, you should see whether there is right ventricular MI. You connect V3. I will just remove all this. What you do? You connect V4R and V5R. V4R and V5R, and you see. And inferior wall, you see the 2-3 EF leads. Okay, that's how. Okay, that's about posterior wall MI. Now we will move to the right ventricular myocardial infarction. Okay, see here. So right ventricular myocardial infarction will have changes where. So right ventricular myocardial infarction, where you will see the changes. So what are the right leads? V1, V2, you will see the changes. Okay, V1, V2, no, V1, V2, but you will see the changes in opposite manner. See, here you can see in right ventricular infarction, it is a right ventricular MI, remember, it is a right ventricular MI. But what you are seeing in the leads, in we will go the regional patterns of leads. Okay, see the inferior leads, there is ST segment elevation. There is ST segment convex and ST segment elevation. That means there is inferior wall MI present. Okay, inferior wall MI present. So reciprocal ST segment depressions are present in one AVL and V5 V6 leads. One AVL, V5 and V6 leads. Along with that, you can also see the changes of ST segment depression in V2, V3, V1 leads also. Okay, so I think this patient is probably having posterior infarction also. We don't know. So because we are seeing inferior wall MI, we should rule out right ventricular MI as well as what do you call posterior wall MI in these patients also. So for posterior wall MI, you will see V1, V2, and you will connect for V2. But this is an ECG of right ventricular MI, so we will go for V4 and V4R and V5R leads now. V4R and V5R leads. See here, it is there here. See here. You can see ST segment elevation with Q wave in V4R and V5R leads. So that confirms there is inferior wall MI along with right ventricular infarction. Both are there. That's why I said no. So these three come in combo. If one is present, you should rule out other two. That's one thing you should know. Okay. I will remove this. So V4R and V5R, when you connect, you are seeing ST segment elevation. So I am having this some schematic diagram for deep explanation of this V4R and V5R. I will take this downside. Now you see here. So right ventricular MI, what you will see, there will be ST depression in 1 and AVL. When you right ventricular MI, when you will use suspect, when the ST depression in 1 and AVL is more than 2 mm, when the ST segment depression in 1 and AVL is more than 2 mm, you suspect right ventricular MI, and you confirm it by V4R and V5R leads. If it is more than or equal to 1 mm elevation in V4R, that confirms the V4R right ventricular infarction. You can see the leads also. In 1 and AVL, the depression is more than 2 mm. So that by that, so you are having an inferior wall MI, but reciprocal changes are there in 1 and AVL. But if the reciprocal changes in 1 and AVL are like this, that are such that the amplitude of depression is more than 2 mm, then you should suspect right ventricular MI in this patient, and you should connect V4R and V5R leads, and you should confirm the infarction. If it is elevated at least 1 mm also, then right ventricular infarction is confirmed. So this is one clue. For right ventricular MI. Second clue for right ventricular, to suspect right ventricular MI, is this one, the ST elevation in lead 3 will be more than the ST elevation in lead 2. The ST elevation in lead 3 will be more than ST elevation in lead 2. See here, the ST elevation in lead 3 is, yes, of course it is more than lead 2. And there will be reciprocal depression at lateral leads, that will be there. So these two conditions, if they are there, these are two conditions. Further conditions are also there. ST elevation in AVF is more than ST depression in lead V2. ST elevation in AVF lead is more than ST depression in lead V2. So AVF is elevated in inferior wall MI, but that elevation is more than the depression in lead V2 in terms of amplitude. So if it is like that, so V2, if it is depressed, and in AVF the elevation is more than the depression in lead V2, that also make you suspect there is some right ventricular MI. So this is the third condition you can remember. Fourth condition, ST depression in V3 should be less than half of ST elevation in lead V3. So that is the fourth condition. QRS prolongation in R precordial leads. So there is, yes, of course there is QRS prolongation in R precordial leads. Okay, epsilon waves in R precordial leads. So this is known as epsilon wave. This arrow, as you are seeing this arrow, no? So this is epsilon wave. So if R precordial leads are having epsilon wave, so that is also confirmatory of right ventricular infarction. Okay, so 5 conditions are there. How many conditions you remember? Just remember this 1 and 2. Okay, and probably these are complicated. This is also easy. These 3 conditions just you remember. The depression, reciprocal depression in 1 and AVL should be more than 2 mm. The reciprocal depression in 1 and AVL should be more than 2 mm. Suspect right ventricular infarction. Second condition is the ST segment elevation in 3 will be more than the ST segment elevation in 2. ST segment elevation in 3 will be more than the ST segment elevation in 2. That is the, so 2, 3 you are comparing. 3 will be more than 2. 3 will be more than 2. 3 will be more than 2. So this is in elevation and this is in terms of depression. Okay. Now you are comparing elevation and depression. This is elevations. This is depressions. And this is elevation and depression. So elevation in AVF should be more than depression in V2. Elevation in AVF should be more than depression in V2. Now we will see these changes in the previous ECG. Okay. In the previous ECG we will see these changes. So that's how we suspect right ventricular MI. Okay, see here. So first of all, you see the elevation. So elevation, as you can see this R wave and see this R wave and see the elevation according to that R wave. Elevation in lead 3 is more than lead 2. So ST segment elevation in lead 3 is more than lead 2. ST segment elevation in lead 3 is more than lead 2. So that is one suspicion. Number 2, ST depression in 1 and AVL should be more than 2 mm. Should be more than 2 mm. Of course it is there. So this is, if a horizontal line, so it is approximately 3 to 4 mm. And this is approximately 2 mm. Okay, this is 2 mm. So in 1 and AVL, ST segmentation depression is more than 2 mm and ST segment elevation in 3 is more than ST segment elevation in 2. Okay, one more condition is there, comparing elevation with depression. Okay, we will see that. So ST segment elevation in AVF, how much ST segment elevation is there? So from the J point you will compare. No, this is the J point. Okay, so if this is the J point, approximately it is 6 mm. This is the elevation. Now you will compare it with depression. Okay, so this is the depression. Okay, so what is the depression? So here it is elevation from here up to here. So grossly, if I just zoom it, okay, I will zoom it, comparing the elevation with depression, see now. Okay, AVF elevation. So this is one large box, this is second large box. So approximately it is 10 mm only. It is 10 mm elevation. and this is one large box, this is second large box. Okay, and this is elevation is up to here. Okay, it's up to here, so it is approximately 6 mm. So AVF, you don't take this point. Okay, you're not taking this point here. Also we are not taking this R wave. Don't take that point to see the voltage. Okay, you take the ST segment, J point. Okay, J point to the maximum point of the ST segment, you take that point. So if you take like that, so here it is, AVF is 10 mm elevation and V2 has depression of 6 mm. So that also, that criteria is also fulfilled here. That criteria is also fulfilled here. And in V4, V4 you, that is also fulfilled. Now next other things which we should see, which we have seen, is this one. You are able to see a epsilon wave here. See, this is epsilon wave, this is epsilon wave. Okay, you are able to see epsilon wave in V4 VR. Okay, that's about right ventricular. When you should suspect the right, just to revise, when you should suspect the right ventricular MI, you should suspect the right ventricular MI, three conditions. Elevations, one is in elevations, one is in depressions, one is comparing elevation with depression. In elevations, the elevation in 3 should be more than 2, and in depressions, the depression in 1 and AVL should be more than 2 mm, and in elevation and depression, the elevation in 3 should be more than the depression in 2. So any one of these criteria is fulfilled, you suspect MI, you just take V4R and V5R and you confirm the right ventricular MI in inferior MI. Okay, now we will move on. So that's about the major infarctions: inferior wall, posterior wall, lateral wall, and right ventricular MI, anterior wall. See here, pathological Q waves we have discussed now. What are the pathological Q waves? So definition of pathological Q waves are: R wave amplitude is this much. So the depression of this should be more than the 25% of the R wave amplitude, and should be, this should be at least one small square, more than one small square width in width. So that is pathological Q wave. The definition of pathological Q waves: all Q waves in V2 V3, this is also important. So all Q waves in V2 and V3 are pathological. All QS complexes, as I said, in there was poor R wave progression, and there are large QS complexes. In the discussion of different type of T waves patterns in ECGs, we have seen the last history cerebral T waves, I think probably, or before that. There were large QS complexes, so that was a marker of previous anteroseptal anterolateral infarction. Okay, so all Q waves in V2 and V3, all QS complexes in V2 and V3. QS complex or Q wave more than 0.03 seconds is nothing but 30 millisecond, nothing but one small square approximately, and more than 1 mm deep in two neighboring leads in the following groups: 1 AVL, V1 to V6, 2, 3 AVF. So these are nothing but localized area of inferior or lateral or anterior infarction. If two contiguous leads are having more than one small square, more than one small square width, or depth of more than or equal to 1 mm. Remember, this is one more strategy: more than one small square or more than 1 mm deep, then that is also called as pathological Q wave in two consecutive leads, either inferior or lateral or anteroseptal. Okay, and all Q waves in V2 V3 are pathological. All Q waves in V2 V3 or QS complexes in V2 V3 are pathological. All Q waves, all pathological QS waves in V2 V3 are pathological. Okay, that you should remember. That's about pathological Q waves. So one more time, all Q waves in V2 V3 or QS complexes in V2 V3 are pathological. Number one. Number two, the consecutive two leads in the different type of inferior, lateral, or anteroseptal leads. If two leads are having Q waves of width at least one small square in width or more than 1 mm depth, then that is, those are also known as pathological Q waves. Okay, that was the general definition: more than 25% length and one small square width. Okay, now here are two examples of ST segment elevation MI. You will just see 60-year-old male with retrosternal chest pain. ECG shows ST segment elevation in inferior leads 2, 3 AVF. There are reciprocal ST segment depressions in AVL and 1. There are also pathological Q waves in the inferior leads. See, so these are approximately one small square width, and the depth is more than 1 mm. Okay, see pathological Q wave. Here you can see. So this is blue arrow indicates ST segment elevation. Pink arrow indicates pathological Q waves. Green arrow indicates ST segment depression. So this is nothing but reciprocal ST segment depression, and this is pathological Q waves. This is pathological Q wave. This is pathological Q waves. At least 1 mm in depth they should be, and they should be in consecutive two leads. So 3 and AVF or 2 and AF are nothing but inferior leads, no? So that's how they are pathological Q waves. So these are also examples for pathological Q waves in infarction cases. So when there is development of pathological Q waves, then the duration becomes more than 1 day. No, hours to, yes, of course it is, I think less than 12 hours development of Q waves. Along with that, if there is depression of uh, inversion of T wave, no, if a pathological Q wave inversion of T wave, then it will become more than 1 day. More than 1 day. Okay. Same thing you can see in the second example. Second example, you'll see. See here. 65 years old diabetic, 3 years duration of chest pain. See, 3 hours. So it is in hours, less than 12 hours. Okay. So ECG shows ST segment elevation, reciprocal depressions and pathological Q waves. So Q waves are there, but T waves are still not inverted. I said no, it will be less than 12 hours. So 2, 3 AVF, they are constituted, at least 2 leads should have. So 2 are having, and they are more than 1 small square width, and they are at least 1 mm in depth. And all Q waves in V2 to V4, they are all pathological. Q waves in V2 to V4 are all pathological. So that's how we have, in detail, we have learned about the Q waves. V2, V3, sorry, V2 and V3. This is one ECG for poor R wave progression. Okay. See here, this is a ECG of normal R wave progression. So what is normal? You see the V3 lead. If the amplitude of V3 lead is more than 3 mm, then it is normal R wave progression. You see the R wave here. So this is one large square, and this is half of the second large square. So 5 plus to 8 mm. The amplitude is 8 mm. So this is a normal R wave progression. But you see here, the R wave is there, but it is approximately or equal to 3 mm. So that's why it is poor R wave progression. So what are the causes of, and QS complexes also you are able to, no, you are not able to see QS complexes because the Q wave is positive here. Okay, Q wave positive. Just you are having poor R wave progression. Poor R wave progression. You should see the lead V3. So pathological, just reminding the previous pathological Q wave. Pathological Q waves are those Q waves which occur in all the Q waves which occur in V2 to V3, all the QS complexes which occur in V2 to V3, and all the Q waves whose width are more than at least 1 small square or 30 millisecond, and depth at least 1 mm. Depth at least 1 mm. Second condition. Third condition, 2 consecutive regional leads. 2 consecutive regional leads, I mean by either inferior region, anteroseptal region, or lateral region. 2 consecutive leads. So these 3 types of Q waves are pathological. I think this is enough for today. We have discussed in detail about the topic of myocardial infarction of different types: lateral, inferior, anterior, right ventricular, okay, posterior also. And we have discussed about in detail about the pathological Q waves also. Thank you, and we will continue. The next topic will be differential diagnosis of ST segment elevation, that we will discuss in the next video. Thank you.